NIPT, non-invasive prenatal test. Today we are going to discuss about NIPT or NIPS. What is NIPT? When NIPT is done? What are the results of NIPT? What to do if the results are positive? What are options for NIPT? Are there any other tests which are required along with NIPT? Or if NIPT is positive, what to do? We'll also touch upon AMNIOCENTENSIS and chorionic Villi sampling. Good morning, I am Dr. Rajat and you started watching our YouTube channel, The Fertility Gynecologist. NIPT, non-invasive prenatal test. What is this and when it is done? At what time of pregnancy it is done? This is the most common questions people ask me in my OPD. So non-invasive prenatal test is a test in which we collect the blood of the patient, a female patient who is pregnant. That blood is usually collected after 10 weeks in a specialized test tube. From that blood, we take the fetal cell-free DNA. Fetal cell-free DNA, that is very, very important. From that fetal cell-free DNA, we test for 4 chromosomal anomalies. Trisomy 21, Trisomy 15, Trisomy 21, Trisomy 18, Trisomy 13, that is Down syndrome, Edwards syndrome and Patau syndrome, and possibly the sex chromosomal anomalies. And we look for specific anomalies in those chromosomes. Why Down's NIPT is advised? See, normally whenever we do call, first of all, let me tell you what we do in our practice. First trimester of the pregnancy, we we examine the patient still about 11 weeks. Once that 11 weeks ultrasound is normal, the fetus is growing properly. When the CRL, crown rump length of the patient is about 55 millimeter, we send to an expert radiologist or a fetal medicine specialist for an NT scan. That is very, very important. This 55 millimeter to 80 millimeter is the time at which the NT scan is done, but we normally do it at 55 millimeter because that is the time somewhere between 12 to 13 weeks, because we also want to get a double marker done. Once that NT scan report comes, then we subject the patient for a simple blood test called as a dual marker or a double marker. This both double marker and NT scan, they give us a predictive value of whether the patient would be having a high risk of a Down syndrome or an Edwards syndrome or a Patau syndrome. If the report of double marker or NT scan is suggestive of that there is an increased risk of a chromosomal anomaly, then the second step we subject to the patient is an NIPT. Now suppose the risk of double marker for Down syndrome is say 1:150, that is a high risk patient, then in those patients we counsel the patient that there is an increased chance that you or baby may be suffering from a double marker, and to rule out, please concentrate on this word, rule out. NIPT has a high negative predictive value. It rules out, it does not confirm. It rules out double Down syndrome in about 99% cases. So we go for an NIPT. Why it is called as non-invasive prenatal testing? Because there is no needle involved. We do not do the puncture of uterus. We do not take the blood of the fetus. We do not take the amniotic fluid of the fetus like we do in amniocentesis or chorionic Villi sampling. We just simply take the maternal blood from a simple 5 ml, 10 ml syringe. We take it into a specialized test tube, take the cell-free DNA, and from those cell-free DNA, we do a chromosomal analysis of the baby. That is why it is called as an NIPT. The ideal time to do NIPT is after 10 weeks. NIPT can also be done without an NT scan. NIPT can be done without a double marker. But we normally prefer to do NIPT after good NT scan and after double marker. Now suppose I have not done an NT scan and baby may be having some form of congenital anomalies. Then it makes no sense to do NIPT in those sorts of cases. A good NT scan at a good place. Why I am telling a good NT scan and a good place, it is very important. I also can do NT scan, but I don't do NT scan because NT scan requires a specialized training. It requires a dedicated personnel to do 3 months, 6 months, 2 years specialized training, and that for a good fetal medicine specialist who is expert in doing NT scan can also diagnose various congenital anomalies. Now if during NT, if I have not seen, I am not doing an NT scan and there is a major congenital anomaly like the baby's head is not there, or baby's head is weak, hydrocephalus is there, or there is a neural tube defect, a spina bifida, or a encephalocele, something like that, in which the prognosis of baby is very poor, then it makes no sense to do NIPT in those sorts of cases because it is a wastage of money. NIPT is a costly test. It costs somewhere from 6,000 to 14,000 rupees. So we have to be very, very judicious. So what we do it at our place, we send till 11 weeks we examine at our place. At 11 weeks, 4 days, 5 days, we send to a radiologist or to a fetal medicine specialist, get an NT scan done. A good NT scan would tell us about nuchal translucency, would tell us about the presence or absence of nasal bone, would tell us about ductus venosus flow, and would also tell us about uterine artery PI. If those are normal or there is any high risk, then we subject the patient for a double marker. Earlier the double marker was offered to the females of more than 30 years, but nowadays WHO has mandated that every female, irrespective of her age, should be offered a double marker because it diagnoses the especially Down syndrome early. In double marker, we do 2 blood tests. In double marker form, NT scan is mandatory. There are 4 values, like I said: NT, nuchal thickness, nasal bone present or absent, ductus venosus flow, uterine artery PI, which have to be filled in the double marker form. These values, along with the patient's age, along with the patient's LMP, they are fed into a software. Some people use Prisca, some people use other. That software calculates the risk of trisomy 21, trisomy 18, and trisomy 13. And then that risk may be 1:1000, 1:200, or whatever. If that risk is high for any particular abnormality, it only comes as high risk, middle risk, intermediate risk, or low risk. If there is a low risk, then we don't need to do anything. If there is an intermediate risk or if there is a high risk, then we need to do. There are 2 options left with us. Either we go for an invasive test like amniocentesis or chorionic villi sampling, or we go for a non-invasive test like a NIPT. The cost of NIPT or chorionic villi sampling or amniocentesis is almost same, somewhere about 14,000-15,000. But a procedure like a chorionic villi sampling or an amniocentesis, they involve putting it under the ultrasound guidance. Amnio means liker, sentences means you take a needle and take the water out. So under ultrasound guidance, we put a spinal needle from uterus to the amniotic fluid of the baby, take a few ml of amniotic fluid and subject that amniotic fluid to the testing. This is the most confirmatory test. But because it is invasive, there is a 1 to 5% risk of abortion involved. Same cases with chorionic villi sampling. Amniotic fluid, amniocentesis we do between 15 to 22 weeks. Chorionic villi sampling involves same under ultrasound guidance. We take the chorionic tissues, that is a bit of a placenta tissue, and subject that tissue to the testing. It is done slightly early at about between 11 to 14 weeks. Again, that involves a minor risk of abortion. So if patient is elderly, patient pregnancy is very precious, there have been multiple previous cases of miscarriages or multiple congenital abnormalities in which we do not want to take the risk of an abortion, in those cases we prefer NIPT against amniocentesis. So what are the indications of NIPT? Can one do directly NIPT? Answer is yes. We don't need to get a double marker done directly after NT scan. We can definitely do an NIPT, but that is specifically done in either somebody demands, or somebody has a history of genetic disorder in the family, or somebody has a previous child of a trisomy 21 Downs or any other congenital chromosomal anomaly, or there are multiple history of abortions. In those cases, we can directly go for a NIPT instead of double marker. Sometimes the patient is late for double marker. Patient has got an NT scan done, but patient is late for double marker. Then we have got 2 options left. Either we go for a quadruple marker combined screening, or we go for an NIPT. Now for Down syndrome, specifically the sensitivity of combined screening or a quadruple scan is only 92% compared to NIPT, which has got a negative predictive value of about 99%. So it is better to go for NIPT along with a genetic sonogram that is done relatively early, 18 to 20 weeks. A genetic sonogram at an expert fetal medicine specialist can be done. Why 10 weeks is the time to do NIPT? Why NIPT cannot be done before 10 weeks? Because after 10 weeks, the portion of fetal DNA increases in the maternal blood. Because if you look at the NIPT reports, the important thing is that for an NIPT report, the cell-free DNA fraction is very, very important, and the minimal cell-free DNA fraction has to be 4 to 5%. If it is less than that, then the NIPT, either the laboratory would request for another sample, or the report would be invalid. So we have to do it after 10 weeks only. The results of NIPT, they are either high probability or low probability. Low probability means for that particular chromosomal trisomy 21, 18 or 13 or 6 chromosome, there are no anomalies involved. So patient can be reassured that there is a 99% chance that there is no anomaly. If the report says that there is a high probability of a specific chromosomal abnormality, then in those cases we would go for a confirmatory test. If NIPT has been done at say 11 to 12 weeks, then we can advise the patient for a chorionic villi sampling. Like I have discussed, it takes the placental tissue, chorionic tissue, and it is done relatively early under ultrasound guidance. If the results are late, say about 40, it is more than 15 weeks, then we go for an amniocentesis. Those are more confirmatory. The cost is same. The results, they take about 14 to 15 days to come. But then Ideally, our target should be that whatever the results are, if there is a high probability of a chromosomal abnormality, or if there are multiple congenital anomalies on ultrasound, and if we want to terminate the pregnancy, that pregnancy should be terminated before 20 weeks. So we want to complete all this procedure before 20 weeks. What if NIPT is positive? I have told we give the patients option to do amniocentesis or chorionic villi sampling. By the time the report comes for NIPT, it is almost 14-15 weeks. So NIPT, the amniocentesis is a better option. Is NIPT 100% accurate? I have told before, NIPT is 99% accurate in ruling out. It has got a good negative predictive value. It cannot confirm that the baby would be having trisomy 21 Down syndrome or trisomy 18 or trisomy 15, the Edwards syndrome and the Patau syndrome, but it will rule out. Okay, so patient can be 99% sure. What is better, amniocentesis or NIPT? Can one do directly amniocentesis instead of NIPT? These are the questions asked to me. Say, if I have got a NT-scan done and that NT-scan is done by a good fetal medicine specialist and that person says that there is no problem, we still get a double marker done, but there are sometimes chances that double marker may have certain influences of age, certain influences of the injection HCG which we give. So if double marker is high risk, then there are two options left to the patient, that we can go for an NIPT, we can go for an amniocentesis. And we can directly go for amniocentesis also. Amniocentesis is a confirmatory test, but only thing is it is an invasive test. There are few percentage chances of risk of abortion involved. To minimize that risk of abortion, we give increased doses of progesterone, injectable, vaginal, oral, everything for about 2 to 3 weeks to decrease that risk of abortion. If pregnancy is very precious, if there are history of multiple abortions, and if after proper counseling we can tell the patient that there is a risk of abortion involved, but NIPT would only give 99% negative predictive value. So in those cases, we go for an NIPT first, with a caveat that if NIPT is positive or there is a high risk probability, then we would definitely go for an amniocentesis. Otherwise, in most of the cases nowadays, patient prefer NIPT. Can NIPT be done for twins or triplets? NIPT can definitely be done for twins, but NIPT cannot be done for HOMP, that is high order multiple pregnancy. It should not be done for high order multiple pregnancy or triplets. Which is better, NIPT or double marker? NIPT is 100% better than double marker. In fact, some doctors, they have routinely started avoiding double marker and directly offer NIPT to the patients because it has got a excellent negative predictive value. But the place where I practice, the economic class of the patients which we have, it is better we offer double marker first, and in only those cases in which NIPT is positive, in which there is a high risk, we offer NIPT. See, I hardly offer NIPT 1 or 2 or 3 times a year to my patients. Double marker I offer about 100 times, 200 times, 400 times to my patients in an year. So I do basically risk stratification. Like I said, a female 40-year patient who has come to me and conceived either with my treatment, infertility treatment, or directly pregnancy, I would offer her a double marker, but I would tell that double marker would be having high risk probability. It is better you go for a NIPT directly. If a 37-year-old patient comes to me and she is an IVF conceived patient with twins, I would definitely offer her an NIPT. But if a 30-year-old patient comes to me, even after her infertility treatment, long-standing infertility, I would offer her a double marker first rather than the NIPT. So in short, I would do NIPT when the risk of invasion is less. That means the pregnancy is very precious. The parents do not want to take the risk of an abortion. Ultrasound, a good radiologist has told me that there are no apparent congenital abnormalities in the baby, and I want earlier results. Amniocentesis, I would think that if your ultrasound is doubtful, if there have been previous histories of a trisomy child, in those cases it is better to go for an amniocentesis bit. This was our small bits on amniocentesis, NIPT and chorionic villi sampling. Hope you like the video. Please support us. Please like the video, subscribe the channel and share the video. Thank you. Bye-bye.